All right, our next speaker is Dr. Katharine Mathews. Dr. Mathews is an obstetrician gynecologist, has worked in the St. Louis area since 1998. She's had a career in educating healthcare professionals as well as providing healthcare to low-income and diverse populations. She joins us today on behalf of her work at St. Louis University as well as Casa, and healthcare organization that provides specific healthcare for Spanish-speaking populations. Dr. Mathews.
It's my pleasure to be here, and please excuse my jean jacket, but I think I would be cold if I took it off. So I just want to do a quick intro on Casa and then give you a taste of not so much the what of the data we collect, but the how and the why. So Casa opened, started seeing patients the beginning of 2010 and opened in response to the closure of 2 other clinics. It's a beautiful physical space. Disappoints some people because they drive by thinking it's a restaurant, and it's not. Our mission is to deliver high-quality clinical and mental health services for uninsured and underinsured patients, focusing on new immigrants and refugees who encounter barriers to accessing other sources of care. And now that we're in our 4th year of seeing patients, we're really primarily seeing Spanish-speaking adults who have limited options for receiving care anywhere else. I put the mission statement up because all that energy, all that good intention starting Casa, when I came on board in late in 2010, really begged the question for me about what kinds of programs we would provide and why. And the best way for me to locate this for you is if I'm an individual physician, which I am, and I'm seeing someone in the office for a visit. If I don't talk to my patient and just go about doing things for her, I really am not doing my job as a provider. So as I came on board at Casa and thought, well, what do we need to be doing in terms of programming? We had a wonderful opportunity. I spent a lot of time, my conversation started at St. Louis City Department of Health, a lot of time talking with Ryan Barker and his team at Missouri Foundation for Health about what data was available. And then what we ended up doing was submitting a proposal to do a needs and strengths assessment called Salud de nuestra población, to get a sense using both quantitative data and qualitative methods of what was really of concern to people within the population we wanted to serve. And I have a shout out to 2 other people in the room, Eileen Wolfington. I feel like anyone who has a promotora here today gets to introduce their promotora. So Eileen is our lead promotora at Casa and also does navigation for our patients. And then Jane McElroy, who partners with us on this project that I'm going to talk about. So I want to leave this map up for a bit because I want to take a moment to reflect on what we've found through our information and some of how I think we can use this in comparison to what has been made available to all of you today from Missouri Foundation for Health. And what I've got here on, if I've got a blinker, anyway, that side is actual census count data from 2010, and then these are the patients, this is where we're drawing patients from at Casa de Salud. And I want you to think in terms of maps, because as you mentally pretend to overlay the map of Casa's patients on the census data, it really begs the question of who are we seeing? What do we know about the people we see? And how representative are our patients of the population as a whole? Likewise, and I had a horrible word pop into my head this morning, you'll have to forgive me. Trigonometry. I was trying to come up with that image from sailing, and I looked up trigonometry, and it's like, okay, triangles, why is this image coming to mind? But if we can take the data that Missouri Foundation for Health has, and we can take the data we have, can we use trigonometry to kind of back into what we think might be information that is helpful and accurate for the population as a whole? And so I want to give you, because I think we're going to have a lot of fun working on this, I wanted to give you a sense because we have, when we first started and before we were on an electronic system, we would collect intake surveys and had about 1,000 respondents. So as Missouri Foundation for Health's data books shows, we see majority men, just over 50%. I can, around things like smoking, tell you that we are seeing a similar population of smokers. Data book said 25%, our data says 24%, but we stratify by gender. And I can tell you that about 36% of our men smoke, but only about 10% of our women. If you remember Ryan presenting information about screening behaviors, what we're being told by our patients, and self-reported data is always tough, especially around things where people want to give the right answer, but what we're finding is much higher rates of not getting access to basic cancer screenings. So for instance, PAP in the last 3 years, which would be current standard for up to date, in the data book, 23% of the Hispanic population hadn't had a PAP. In our data, 32%. No mammogram, we asked within the past 2 years, because if you go by kind of National Cancer Institute and some of the other evidence-based recommenders, that's within range for evidence-based. 65% of women who were age appropriate for having a mammogram had not had one in the past 2 years within our data, and in the data book data, 40%. So that already raises a question, you know, maybe by age and gender breakdown, we're seeing similar populations, but in other ways, maybe the population we see is a little bit different from the population that's showing up in the data book. And in particular, what I'm able to do and will be doing over the next few months is going in and looking in at things like employment status. I actually think that our data will show that a high number of our people are working, so maybe not showing the unemployment rates that the data book showed, but not always working in the official labor sector, so kind of a very different zone for doing work. Insurance status. We're very careful not to ask patients because we don't want to put up any barriers, and we actually don't bill insurance. But we know as we do navigations and referrals that it's highly unlikely for any of our patients to have insurance, so that rate in the data book wouldn't reflect our population. And then the other thing, and Ryan talked about this a little bit, is emergency department use. And ironically, so when Casa was just being formed, there was the claim made that any visit to Casa was an averted emergency department visit, and that didn't really sound right to us. So it's something we've tried to explore in a variety of ways. And it is often the case that we have people walk through the door and they're so sick that we end up sending them to the emergency room. And because we can send a navigator, we can overcome some of that fear that Ryan talked about, reasons why people don't want to get into the system. So back to this whole issue of collecting data and how it helps inform our programs. You know, at a most basic level, it's helping us understand the population as a whole, and for me, data questions are very much related to ethical imperatives. So I want to now talk about the other part of our project and just describe a little bit about what we've done, because I'm not going to show you results, and I'm sorry if this is hard to read, but let me back up because that is a little hard to read. So the other piece of this project involved 43 key informant interviews. And again, if we're thinking trigonometry, some of what was presented earlier today, yes, we heard a lot of those same themes. Themes around all the confusion with how you pay for care if you're uninsured. That's a huge space for us where we're working. But the themes didn't just come up around healthcare system, and that was one reason I have these questions here. So just to read off a couple in English, we ask around issues around culture, what it's like to be in the St. Louis Latino community, and what does community mean? What changes do you have to go through as you come into this community? What are the strengths that you have within our community in terms of enhancing health? So as we went through this very open-ended and fairly long interview script, with 43 people, we have gathered tons and tons of information, and actually at a preliminary analysis, we've got 19 different buckets or nodes in terms of categories that came up around health. So it will be, I look forward in the coming months and year or so to being able to share more of the themes that have arisen from this, but I wanted to tell you that one of the big issues for us around collecting this information was bearing in mind the population we were working with, and again back to the imperatives that we use within medical care of first do no harm. We're often very mindful of how we share the information, and we've been very mindful of where the information goes first. So as we're in the process of analyzing these themes, we're also bringing this back to stakeholders from the Latino community itself to make sure that what we heard was what people said, and we've actually used that process with individual interviewees. And also, as valid as these responses may be for the people we spoke to, are they valid for people who've had different experiences? And how can we expand on our understandings by hearing some of the contrast with what we've heard from the people we spoke with and what other community groups may have experienced? And so final thoughts, and I look forward to more of your questions later. All the questions around data, whether it's valid, is it valid for the people from whom we've collected it? If it's valid for those folks, is it generalizable to larger populations? Ownership. Karen Edison brought up that it really matters for communities to own information, which is one reason why we're taking this information back and really going to the community itself in terms of setting priorities with how we use the information we've collected. And I think really through those processes, those participatory processes, really working with community, that's where we get the power for positive change. So I thank you for your attention.
Thank you very much. You know, we've heard two speakers now mention the importance of navigation, patient navigation, in terms of being able to provide those services, and I think that's going to generate a lot of questions for us.